Hi, welcome to a little tutorial I thought I'd do on brow ptosis, eyelid ptosis, and how to prevent, diagnose and treat this relatively common set of problems. The first thing we'll discuss is brow ptosis. So a brow ptosis is caused by over-denervation of the frontalis muscle, and it happens in certain people. So there are people where you can completely treat the frontalis muscle to the point where nothing moves, but they still don't get a brow drop. But there are others where you'll get severe brow drop with even partially treating the frontalis muscle. I'd rate it as a relatively common side effect, so about 1 in 100 people may get this. It is preventable through good client selection, and you can also prevent it by knowing about certain injection patterns and having a method to reduce overtreatment, so by identifying muscle that you need to protect in order to prevent a brow drop. The first thing is client selection. So here I have 3 examples of clients you want to be careful with. This lady on the left has quite a lot of loose skin above her eyelids, and even if you drop her eyebrow a millimeter up here, you can actually affect her vision. You'll actually drop it a further millimeter here, so you would not treat this woman's forehead at all. The middle lady is a lady who's got a little line crossing her nose and a sense of kind of bulkiness around the glabella area. And similarly, a little bit of treatment here may transmit a fair amount of energy here and make this already heavy area look even heavier. So this is another type of forehead just to be a little bit careful of treating when you treat the frontalis. The third lady just has a kind of a bulkiness. So if you compare her glabella area to this lady's glabella, you can see that there's just considerably more tissue here that just may hang down. There's a little bit of loose skin, or not necessarily even loose skin, but just skin that is very, very close to the eyelid, and if you drop that a millimeter, she will see that. Even half a millimeter, she'd probably sense it. So this is another type of forehead where you want to be really careful about treating in this section here. So let's have a look at where you'd actually inject. So as part of your foundation training, we did cover little safety areas where you're careful about injecting, and this is largely to prevent these brow ptosises. So this central box here, or there's almost like a goal post, some people refer it to, between the mid-pupillary lines and about 2 centimeters up minimum, there's an area here where you want to try your best not to put any Botox. Then there's also the area above the eyebrows, which is even more sensitive, and there's an area here where you want to be very cautious of putting Botox in, or you affect eyebrow movement and eyebrow lift. So what this really means in practice is that around about 2 centimeters from the eyebrows, or in some cases if the forehead's very small, it might be 50% of the forehead, we try and leave protected, so untreated. If you look at these various different diagrams, which are also in your manual, you'll notice that all of them include quite a lot of space between the eyebrows and where the injections start. And this is all to prevent brow ptosis. Once the dots are actually well placed, you don't actually need to worry about injection technique. Obviously, we want injection technique to be excellent for your client's sake, so that it hurts less and causes as little trauma as possible. But in terms of getting a result, if you put the Botox in where the right place is, even someone who's not very good at injecting should not be able to cause a brow ptosis, because your injection points are the most important factor. Dose also has a role, so obviously if you put 8 units in instead of 1 unit, that's going to increase the chance of getting a ptosis, but it's the position of the injections that's most important. So what actually happens when your client has a brow ptosis? They'll often ring up describing quite awful sounding symptoms. So people often want to be seen. They're upset because they're expecting something good, so they'll often state things quite emotively. So you hear things like my forehead's collapsed, or I look like I've had a stroke. These sorts of awful, scary things that you see, that you have clients say. Fortunately, when you see them, don't often seem to be as bad as that, and even the clients emotionally are often better when you're seeing them and treating them. Not always, but usually. So the kind of symptoms people report are, the most important one to know about is they often Google it and they find about eyelid heaviness. So they'll tell you that they have an eyelid ptosis when in fact they have a brow ptosis, and it's a really, really common situation. So whenever someone rings up saying my eyelids have dropped, just take a deep breath and reassure yourself that 9 out of 10 times, probably even more than that, when you see them, their eyelids will be fine and they have a brow drop, which is thankfully a bit easier to treat. So they may also report sensations, so the forehead just feels heavy or feels like they're wearing a swimming cap. They may report that they look tired. They were hoping to look more alert and wide awake, but instead they look tired. Sometimes it's a functional difference that they notice. So it's when applying makeup, that's particularly obviously with women, when you apply eyeshadow or eye makeup, they tend to lift their eyebrows, and if that muscle no longer works and they have to start using a finger, it's rather annoying for them. So that's often what they report, rather than something that you can see. It's just the function that they miss. And I've already discussed there at the bottom that they can report it as a ptosis if they've been Googling an eyelid ptosis, and don't fall into the trap of just prescribing apriclonidine drops, which we'll get to later, without examining them. Okay. So what are you looking for when you examine someone who's reporting symptoms of a possible brow ptosis? First, let's think about what the key goals are. You're really trying to find out two things. Firstly, is it really the brow that's dropped, or is it the eyelid? Because the management is totally different. And the second thing is, are there actually brow depressors that are actually aggravating the problem? Because if there are, that's actually a good thing for us in this situation, because if your orbicularis oculi, your procerus, or your depressor supercilii are all contributing a pull downwards, those are all muscles that we can safely treat and allow the eyebrows to then lift up again. So the first thing you normally would see in a proper brow ptosis is the brow is usually fairly immobile, or with maybe a very tiny amount of movement, but basically it's immobile. If it is mobile, you want to be checking the depressors, and you do. And I have seen this on a few occasions where people have actually had very, very strong depressor muscles, which is the reason that they've got the ptosis. So they can have normal forehead movement with a ptosis when they've got very strong orbicularis oculi muscles, for example. You may also see, and this is worth making a mental note for your own development really, is you'll notice at the point where they come back the various characteristics that I pointed out a few slides ago, where you actually see that, okay, this person did have a line across their nose, or they did have that loose skin above their eyelids, and now that I've caused the problem, I'll never do it again, because you'll remember that look or that type of face, and be more careful not to treat them next time. The final thing to look at would be the iris. So to rule out a ptosis, probably the easiest thing is to just consciously analyze where the eyelid is meeting the coloured part of the eye, or the iris, and you just want to see a normal amount of it, and usually fairly symmetrical. A lot of people are asymmetrical. I'm actually quite asymmetrical, so I look like I have a slight ptosis on my eye, and you may see that in one of the pictures where I've included myself. So that's actually fairly normal. Really, you want a before and after picture to compare, just in case there's a little bit of asymmetry that's pre-existing. But a real ptosis is usually pretty obvious, and there's no doubt when you get a real one. Okay, so what are your treatment options for a brow ptosis? You've got conservative options, so you've always got the option of just leaving it and waiting. Mostly people will report a small improvement after around about a month. And then obviously within 3 to 4 months they get a big improvement because the Botox starts to wear off. You could ask them simply to exercise any remaining muscle. This works well when there is a little bit of movement. So if there's a little bit of movement and you focus your attention on exercising that muscle that remains, hopefully that muscle will get stronger and lift the eyebrows better. The third option is the one I do most often actually, which is treating the remaining brow depressors. So you need to consciously work your way through analysing the activity of all the depressors, so orbicularis oculi, procerus, depressor supercilii, and the corrugator muscles. The corrugator, sorry about that little typo there, but the corrugator is only a weak depressor in most people, but in some people the angle of it makes it quite strong. Your strongest depressor is orbicularis oculi and procerus, and those can be treated in 2 different ways, which I'll come to next. So the safest treatment option, which I've indicated in this photograph, is to treat it as if you were treating the frown or crow's feet. So it's really the same pattern you might do, but you may target the depressors more. So for example, in this diagram I've got 3 injections where the frown lines are, and that's because they represent the procerus, the depressor supercilii, and the bulk of corrugator. and that would help lift a medial ptosis if you'd not treated the frown before they treated their forehead, which by the way is what I'd recommend you do with everyone. You should really do the frown at the same time as the forehead for most people. The next area is at the tail of the eyebrow, where orbicularis oculi is pulling down on the eyebrow. That's a great place to add a little bit of Botox if you've not already treated the area. And just 2 injections there, maybe of 2 or 4 units in each one, which would apply to all these dots I've put here, will just allow the natural elasticity of the skin to lift up a little bit, and you get 1 or 2 millimeters back if you've got brow drop. Doesn't sound like a lot, but it's well worth having. Okay. So I've got a little video here. You can see, as I was saying, I have a slight asymmetry to my eyelid. That's nothing to do with Botox. It's just always been that way. But really, I did this video to show you how powerful the orbicularis oculi muscle is in its superior aspect. That's the bit that we don't normally inject. So let's have a look at this. So if you watch in slow motion as my eyes contract, watch what the eyebrows do. So there's a really big drop in the position of eyebrows during contraction. It's probably a full over 1.5 centimeters of strength that's pulling the eyebrows down, and that is all coming from this part of the orbicularis oculi within the eyebrow and a little bit beneath, that even at rest must be pulling down on the eyebrow. So it's a place that you can treat to lift the eyebrow when you're desperate. Now, it is risky because it's closer to the eyelid. If you've got a 1 centimeter or so gap, that's pretty handy, but there are some other things that you should always do to reduce the risk of causing an extra problem. And I don't recommend you do this on everyone, and I recommend you do it when you've got some experience, a lot of experience really with your simple treatments. But it is something that is done in clinical practice, so I think it's worth sharing it on this forum in particular. Okay. So the first thing is, this is off license, so even though we're treating crow's feet on license, this would probably count as an off license treatment. You want to change the dose to make it a little bit less likely that you'll get spread. So if you start a new vial of Botox, you want to use the most concentrated form, so about 1 ml per 100 units, which means for once your marks on your syringe actually line up with what you're injecting. So it will just be one of the tiniest gradients on the syringe for each injection point. You must inject superficially. The orbicularis oculi is obviously the most superficial muscle here anyway, but it's deep injections that we think cause eyelid ptosis anyway. So be really cautious of deep injections here, because you don't want to cause an eyelid ptosis on top of your brow ptosis. So small injections of 1 unit superficially with a concentrated form of Botox, and you should be able to get a useful lift from treating clients you're desperate to help in the situation. This is also obviously something you can do if you want to lift eyebrows that just haven't lifted as much as you want. You occasionally will meet people who want an eyebrow lift, they get a tiny one and you're desperate for more. You can talk about the option of treating them this way, but just be clear that the risks will be slightly higher of a droopy eyelid. I've still never had anyone get one from this treatment, but obviously if it's closer, the risk is higher. Okay, a couple of consultation tips. Just remember, in this situation, clients are often very upset. They have all sorts of anxious thoughts in their head, for example, that it's going to be permanent. So be reassuring. So improvements will come for sure. Even if you do nothing, they will get better. But sometimes they come sooner. So you may get an improvement by doing nothing in the first month. Possibly also useful to explain what you would do differently next time. And this is partly about client retention. So explain the problem, explain where the injection was that's probably caused the heaviness that they've got, and how you could change the treatment next time to mitigate the risk. I think it's worth saying that it's a known side effect. Some people think it's the first time ever this has happened, and that they've got, in inverted commas, Botox has gone wrong. And it's worth saying it's actually a pretty common side effect. Obviously, you should have covered this in your consultation anyway before you started. But if you forget to do it, or it wasn't emphasized enough and they've forgotten, it's still useful to remind them that this is kind of one of the things that happens, and it's part of a whole range of things that can happen when you take the risk of having a Botox treatment. But it's also a temporary, short-lived effect that you can hopefully reduce at subsequent treatments. So the more upset they are, I always think the more love they need. So the worst thing you can do is respond to an angry or a client with being defensive, because it basically just gets worse and worse, and the anger gets worse. So give them some love. That's basically what I say. So care about them, let them know that you care about the result, let them know that you're disappointed yourself. Obviously, we all come into this arena to make people feel good about themselves, and when you fail to do that, it's very upsetting. It's a really bad day for you as well as for them. I don't think it does any harm sharing that information with them. Okay, so next section is eyelid ptosis. So these are caused by an accidental denervation of the levator palpebrae superioris. So that's obviously the muscle that actually lifts the eyelid. It should be very, very rare. My experience is that I've had 0 out of around 25,000 procedures. So I say, less than 1 in 10,000 with a good technique. So that's all important. We'll cover the technique again, which was all on the foundation training course, but we'll cover it again here. With improper technique or with poor technique, it's actually quite high. In fact, in the first, if you read some of the initial trials that were done with Botox decades ago, they were quoting 6% as the risk of eyelid ptosis, and that is purely down to injection technique, because if I was getting 6% of my clients with eyelid ptosis, I think I would have given up by now. That would be horrendous. So it's nowhere near that if you inject well, and I'll talk you through that next. So the first thing to know about preventing an eyelid ptosis is the anatomy. So we all are quite good at looking at a textbook and learning the two-dimensional anatomy, and that's why this is a problem, because the problem is in understanding the three-dimensional anatomy, not the two-dimensional anatomy. Key fact is that the procerus muscle, procerus as well, but the corrugator muscle starts really deep and on the bone, and then as it travels laterally, it becomes more and more superficial until it's actually embedded in the surface of the skin. So there are fibers that are actually in the dermis, and your injections really should reflect this change of depth. And when they don't, it's this lateral injection just above the midpupillary, just on the midpupillary line. It's a deep injection here that causes eyelid ptosis. And I think what's happening is it's basically missing the muscle, going underneath the skin, and then working its way into the eyelid. So there are two things that I like to do to reduce that risk. The first one is make sure that your injections start deep and become very superficial as you work medial to lateral. And the second thing is, I think it's useful for the dose to do the same. So you've got a strong part of the muscle in the middle, and the muscle fibers basically get weaker and thinner as you go to the side. So effectively, what I do is I take what is the licensed dose, which is 5 injections of 4 units, and I split the lateral injection into a 3 and a 1. So I have in the middle of the corrugator muscle, I put a 3-unit injection, and then laterally, very superficially, where the risk is highest of causing a ptosis, is where I put the lowest dose of 1 unit. So my pattern tends to be 4 units in the procerus, 4 units in the deepest, strongest part of the corrugator muscle, where it overlaps the depressor supercilii, and then 3 units in the middle of the corrugator muscle, and 1 unit laterally where the muscle is thin and small and the fibers are superficial. And that injection technique has kept my record completely clear, and I want all of you guys to have the same low risk chance of getting a ptosis. And that's how you do it. Okay, so let's look at how you diagnose a ptosis. So really, it's about, obviously it sounds obvious, but looking at the eyelid and how it interacts, how it overlaps the iris. So with a proper ptosis, you should see, as in this picture, a very clear asymmetry, unless you've caused it on both sides, which would be super unlucky, but I suppose possible. But you're looking for where the border of the eyelid crosses the iris, and that's worth seeing, because a lot of people who come and say they've got eyelid ptosis, they're talking about loose skin above their eyelids, and it's actually resting down from the frontalis, so it's not really the eyelid that's affected. You can also do a test by manually lifting. If they can move their frontalis, that's a pretty good guide that it's not a brow drop. But also, if they can't, you can always lift the skin, and if you see the eyelid pretty much stay where it is, then that's also another guide that it's the that it's the muscle lifting the eyelid that's affected rather than the frontalis muscle. There may be dryness associated. That's worth finding out as well. So if they have a dry eye that's also droopy, then you've definitely got a lot of Botox in the wrong place. But I think that would be also very unlikely. Okay, so how do you actually treat this scenario? So there's only really one widespread treatment that I hear about. It's off license, but it's apriclonidine drops. So suggest you look them up on the BNF if you ever do need to prescribe it. But it's basically 1 drop 3 times a day. And the way that they work is that they are sympathomimetics. So it's a sympathomimetic drug, so it acts a little bit like our sympathetic nervous system would. So sympathetic nervous system, your fight or fright reflex, and what you're doing is essentially widening the eyes as you would do if you got a fright, but you're using a drug to do it. And it works on the smooth muscle rather than the striated muscle. So it's not actually treating the muscle where the problem is, it's using a different mechanism to cause the same effect. It works quickly, which is good, but it has a short half-life, so it doesn't last long, so you need to use it approximately 3 times a day. If you don't get an improvement, I firstly possibly question your diagnosis, but also there is no point in using it. Some clients have given me the impression that they feel like it's when they were told to do it, that it's really all about kind of solving the problem, which it isn't. It's about treating the problem, and if it doesn't work, there's no point using it. Okay. Be reassuring as well. Same as the other things. Be reassuring. Improvement normally takes about 6 weeks without the drops anyway. Explain what can be done to avoid the problem next time. So you may say about changing your injection technique or avoiding the frown area. I would also say remind them that it's a known side effect, but acknowledge their feelings on how upsetting it is. And the same as last time. The more upset they are, the more love they need, and all of this will help really just avoid the situation getting worse. With kind of your worst case scenario would be them attempting to sue you, which I'm convinced most people do because they feel disregarded and not looked after, rather than the fact that they have a droopy eyelid. That's one of the bad things, but most people who get a bad side effect, as long as they know that you care about it, they don't want to hurt you back. It's when they feel you don't care that it becomes a court case. So just care for your clients. I think it's the right thing to do anyway. Okay, so that's everything. I hope that helps, and if you ever get in this situation, obviously we can review this little lecture again, and or contact us on the Facebook forum as you often do. But I hope that puts you in a much better position to avoid it, and also to look after any clients who get this problem. Thank you.